My talk is about MRO Rads risk stratification from evolution to applicability. What's MRO Rads? The Ovarian Adnexal Reporting and Data System MRI Committee formed under the direction of the ACR and includes a group of experts on adnexal imaging and management who developed the ORADS MRI lexicon and risk stratification system in a continued effort toward global standardization of radiological reporting. The scoring system assigns the probability of malignancy based on the MRI features of an adnexal lesion and provides information to facilitate optimal patient management. Evolution of the MRO Rads stratification. As we all know, ultrasound is highly sensitive and specific for excluding malignancy when the classic benign features are present. The positive predictive value of cancer drops when the classic benign features are present. The positive predictive value approaches 100%. Yet, when the lesion has indeterminate imaging features at ultrasound, it drops between 7 to 50%. And when the lesion has ultrasound imaging features worsen for malignancy, it rises mildly to between 29 and 50%. MRI has the ability to increase the positive predictive value for cancer to 71% with a negative predictive value of 98%. The ability to exclude malignancy is one of the greatest strengths of referring sonographically indeterminate adnexal lesions to MRI. At MRI, the presence of enhancing solid tissue in adnexal lesion is the primary driver for risk stratification. In addition to excluding malignancy, the high soft tissue resolution and the ability to characterize the composition of different types of fluids allow for more accurate characterization of lesion type. Furthermore, the multi-planar capabilities of MRI allow for interrogation of the entire lesion regardless of the lesion size or location. This is particularly important in large adnexal lesions with small papillary excrescences or soft tissue nodules, both of which may be incompletely evaluated with ultrasound. The gynecologic community considers MRI the non-surgical reference standard for adnexal lesion classification, and pre-operative MRI is particularly helpful when fertility sparing surgery is being considered. The ACR ORADS MR stratification system. The ACR ORADS MRI committee published a lexicon and risk stratification system for adnexal lesion on 2020. The ACR lexicon includes standardized terms and definitions for assessing and reporting adnexal lesions, and the risk stratification system provides a data-driven means for assigning the probability of the malignancy. The primary goal from risk stratification system is to improve the communication between radiologists and referring physicians in a reproducible fashion, so that women with benign lesions or borderline tumors can avoid unnecessary or overextensive surgery, while women with potential malignancy are promptly referred for oncologic surgical evaluation. The lexicon mean descriptors was derived and organized into 7 major categories. I will not go in much details, yet I'll talk about the major categories. First, the major categories including physiological observations such as Graafian follicles, corpus luteal cysts, and lesions, whether they're benign or malignant lesions. Size, the maximum diameter of the lesion, shape or contour of the solid tissue or the solid lesion, the signal intensity, homogeneity, T2 signal, T1 signal, and the diffusion signal, the lesion components, cystic component descriptors, and solid component descriptors such as the lesion borders, enhancement, and this includes dynamic contrast and non-dynamic contrast enhancement, and general and extra ovarian findings such as ovarian torsion, peritoneal thickening, and nodularity. I marked in red number 4 and number 6 because they are not considered anatomical methods of assessing a lesion. They are considered functional ways to assess the lesion. As in diffusion, as we all know, this is a normal tissue, free water motion between the cells, and when there is packed cellularity, increased number of cells, there is restriction of the motion, and hence restriction of the motion makes the lesions more visible. And the enhancement reflects the neoangiogenesis. The malignant cells invites the blood vessels to come to nourish these malignant proliferating cells. And the enhancement pattern is considered in two ways. The dynamic curves, as we can see, this is a low risk dynamic curve in which the lesion, there is shallow small apprise, much lower than the accompanying myometrium, and the intermediate risk lesions in which there is moderate apprise followed by plateau, and the third one, which is the high risk one, which is more steep than the myometrium, followed also by plateau. MRI like a puzzle game. Okay, every information we get from each sequence like part of the puzzle. We collect them together so as to reach to a final diagnosis properly. The ORADS scoring system, first score 0, and this is when the lesion is incompletely evaluated at MRI. This includes lesions that are incompletely imaged, where portions of the lesion are not assessed, such as enlarged lesions not included in the field of view, technically inadequate MR examinations, where all the required imaging sequences have not been performed, such as lacking diffusion images, lacking dynamic contrast studies, and if there is a large amount of artifacts. MR score 1, in which the ovaries are normal, or we have follicles less than 3 centimeters because it's considered a graphene follicle, or small hemorrhagic cyst considered also a hemorrhagic graphene follicle or corpus luteal cyst. It's worth mentioning that all these categories only categorized as ORADS 1 if this patient is premenopausal. And after menopause, any of these lesions will not be considered, whether they are follicles, hemorrhagic cysts, corpus luteal cyst, will not be considered no longer as ORADS 1. ORADS 2 has many types. For cysts, they are mainly unilocular with no solid component, or dermoid cyst. Solid components means fibroma, which are dark on T2 and dark on diffusion, or extra-ovarian finding like dilated fallopian tubes or para-ovarian cysts. As for the solid tissue, that is the lesion component that enhances and conforms to one of these morphologies: papillary projection, mural nodule, regular septation wall, or other large solid portions. For MR ORADS 2, unilocular cysts of any type of fluid should having no enhancing warts or no solid tissue. This is a hemorrhagic cystic lesion. As we can see, this is high T1, high T1, high T2, not suppressed on fat suppression sequences, and on subtracted images, we didn't find any enhancement. And also other unilocular cysts, whether these are containing simple fluid, large cysts containing simple fluid, high T2, low T1, no diffusion restriction, and fine smooth marginal enhancement on post-contrast study, or endometriotic fluid. As we can see here, it's dark on T2, high on T1, not suppressed on fat suppression sequence, and having smooth marginal enhancement. Also, dermoid cystic lesions considered as benign finding and scored as MR ORADS 2. These are dermoid cysts, typical appearance, having fat fluid level with a Rokatansky nodule floating. That is, the fat is suppressed on fat suppression sequence and no enhancement on post-contrast study. Minimal enhancement of the Rokatansky nodule is accepted and doesn't change the ORADS from 2 to 4. This is another case. She was referred because the referring physician, the referring gynecologist was worrisome if it is dermoid. On T1 and T2, it's not typical for dermoid because on T1 it has heterogeneously low signal, and on fat suppression it doesn't much suppress like fat. Okay, and it has central diffusion restriction, so we got confused if this is a dermoid cyst or not. So we did for her in and out of phase. This is the in phase, and after we had out of phase, there is complete loss of signal, and this was intracytoplasmic or intracellular fat, and this was proved later to be a dermoid cyst. Okay, as for solid lesions, as we talk about cysts, and they are unilocular cysts lacking soft tissue or dermoid cysts. We have also the solid lesions in the ORATs too, provided that they have dark T2 signal and dark signal on diffusion, and homogeneously hypointense on both sequences. If I didn't have homogeneous dark T2 or homogeneous diffusion, I'll change the pirates of this solid lesion. And this is a fibroma. A typical picture looks like the leiomyoma of the uterus. Okay, the non-ovarian lesions, here is a hydrosalpinx, left-sided hydrosalpinx, can show enhancement, minimal marginal enhancement, but should lack any enhancing solid tissue, as we said before, or simple para-ovarian cyst that is also having lacking any solid soft tissue component. For MRI score 3, we have the unilocular or multilocular, and both shouldn't have any solid enhancing component. And as for lesions with solid tissue, excluding that previously mentioned, should have low risk time intensity curves or dilated fallopian tubes. This is a unilocular cyst having proteinaceous hemorrhagic mucinous, high in both T1 and T2, not suppressed on fat sat, and having smooth marginal enhancement. And this is a multilocular cyst that is having simple fluid inside, no enhancement, no solid tissue enhancement, just fine enhancement of the septa on the sun-tracted images. For solid lesions scored with ORATS 3, those lesions that have inhomogeneous either T2 signal, low to T2 signal, or inhomogeneous diffusion restriction, but they have low risk pattern, time intensity curves on the dynamic study. And dilated tubes, this is a case of BID, in which this is a pyosalpinx. We can see the fluid leveling, the diffusion restriction in the fluid levels, and the marginal enhancement, which is thick yet no enhancing soft tissue component. As for lesions with ORATS 4 and ORATS 5, here we will talk about the solid tissue. Either this solid tissue is accompanying a cystic lesion, such as these papillary projections, which have intermediate risk time intensity curves, or we don't have a dynamic study, as in here. This is a solid tumor with restricted diffusion, but the enhancement pattern is quite similar to the surrounding myometrium, or a dermoid with large solid enhancing lesion, and this is suspicious and turned to be out dermoid with a squamous cell carcinoma. As for ORATS score 5, this is a solid lesion with high risk time intensity curve or enhancement in the more than the surrounding myometrium, or other signs of malignancy such as omental nodularity or irregularity. As in this case, there is large solid component of restricted diffusion and suspicious time intensity curve. The lesion is steeper in enhancement than the adjoining myometrium. Okay, and this is marked diffusion restriction. And here, as we can see, the lesion is enhancing more than the adjoining myometry. This is another case in which there is a large solid mass lesion invading evenly the anterior abdominal wall and the large subcapsular hepatic deposit. What are the implications of management? Currently ongoing studies evaluating the effect of ORAD's MRI stratification risk on the patient management plan. Once these studies are complete, the ORAD's MRI risk stratification system will include management recommendations and the system will evolve. The take-home points: the ORAD's MRI lexicon is a multidisciplinary international initiative with the goal of developing standardized terminology for the evaluation of ovarian and adnexal lesion. The lexicon is used in the ORAD's MRI risk stratification system to assign a malignancy risk to adnexal lesion and provide actionable information in the imaging report. Characterization of adnexal lesion is mainly based on the combination of morphological features with its functional properties on the fusion and dynamic contrast enhancement. The non-specific term, which was previously all we use, complex adnexal lesion, was eliminated and replaced by concise descriptors of the lesion morphology. Consistent application of the ORAD's MRI lexicon terms in a standardized report have the potential to increase the accuracy of lesion characterization, improve interdisciplinary communication, and to promote optimized patient management of adnexal and ovarian lesions. Thank you.
Any questions?